people will hold out going to the emergency room because they know it's going to be expensive, because they know they're uninsured, they know there's a problem here. Medicaid pays for almost half the births of this country and more than half of the nursing homes of this country.
Today on Community Health Centers Unfiltered, we're going inside Medicaid at a moment when the ground is shifting in real time. Over the past few years, the Medicaid program has gone through significant changes. As coverage is shifting, states are taking different approaches, and new federal policies like H.R. 1 are beginning to take shape. Across the system, there's a shared focus on how to maintain access to care while navigating evolving and persistent demands on workforce, funding, and delivery. At the center of all this are community health centers and Medicaid health plans, two essential parts of the system working toward the same goal of serving patients and communities. My guest today is Craig Kennedy. He's the CEO of Medicaid Health Plans of America. Craig has spent his career at the intersection of policy and practice, from Capitol Hill to advocacy for community health centers, and now leading Medicaid health plans across the country. In this episode, we take a closer look at what's happening inside Medicaid right now, and what it means for health centers on the front lines and the patients that they're serving. We also explore how plans and providers can continue to strengthen their partnership to deliver high-quality care for the people who rely on this system every day. Let's get into this important conversation. It's going to be a good one. Hi, Craig.
Hello, Amanda.
Can you see the smile on my face? I'm really excited to talk with you.
So excited.
Very special day on Community Health Centers Unfiltered. To get us started, would you please introduce yourself and tell us a little bit about who you are and why you're here?
I would be happy to, Amanda. As you well know, I am Craig Kennedy. I'm the president and CEO of the Medicaid Health Plans of America. I've been in this role for 6.5 years, just over 6.5 years. Before that, I was the executive director of the Association of Clinicians for the Underserved, about 6.5 years there, and then 14 years at the National Association of Community Health Centers, as you saw in my bio. But before that, worked on Capitol Hill in both the House and the Senate, and then before that, the Oregon State Legislature. So a long line in the public policy space going back to the early 1990s. So a bit of transition over those times.
You know that makes you old.
I have heard that. A couple of times, mainly from my children. But yes, I've heard that more and more these days. So, and the gray hair.
I'm right there with you. I'm chasing you.
Yeah.
So it's okay. Mm-hmm. So I will start by just saying thank you. So for those who don't know Craig or are not familiar with his history, he mentioned the sort of path that he has taken to now be the CEO of Medicaid Health Plans for America. But he spent a large portion of his career supporting health centers. And I would say the impact that you had in that work cannot be overstated, specifically as it relates to the Affordable Care Act and the massive expansion of the health center program under your leadership. I also may have been working with Craig at that time. But I say that really, truly, because you deserve a lot of credit, and the role that you played in getting health centers to where they are today, and what we see of them 60 years later, that's a big deal because of your work. So thanks for that.
Can I give you a little bit of the history of that, which was I was working on Capitol Hill when I first met community health centers. I was working for a gentleman from Oregon, and we were on appropriations committee. So I was doing his appropriations work, went out to Salem, Oregon, and was touring. I did all domestic policy, so everything that had to do with people in America, all the things, and didn't really know that healthcare was my calling, but I had worked in Senate finance prior to that. So I went out to Salem, toured the health center there in Salem, Oregon, and it was in a converted Safeway, so a big footprint of it and a good location for the community. But the conversion was less than ideal.
Special.
Is how I will phrase it. Less than private for the folks coming in to do medical visits. And I thought to myself, wow, this is a great program, but boy, they need help. They need help to do this up a level. And that year there was a big push to cut community health centers. And I was like, oh, you're not cutting community health centers. We need to grow this program. We eventually stabilized it that year, but then worked on growing it from there on out. But I still remember touring that first community health center in that converted Safeway. We eventually were able to grow it. I think I got a staff award for level funding the program in 95, 96. And I was angry. About it. I was like, I'm getting an award for level funding this program? And I remember I stood up there with another gentleman from Henry Bonilla's office, got the award as well. Eric Fox was his name. And Eric Fox, and he looks at me and he goes, kind of weird to get an award for level funding a program, right? I said, that's because I think they're doing the best they can, but we need to push this. And then eventually I joined, 99, I guess, and then the growth from there, when I started at NAC, we were at about 8 million people. And by the time I left, we were 24, I guess. So tripled the program by then. And then, as you noted, the Affordable Care Act trust fund had been established. I left just before that fifth year kicked in. So I still take a little bit of the credit for the fifth year, even though I wasn't there, but excited to see the growth and always still wanted to see everybody have access to a community health center, which was kind of the goal.
Yeah, that's why we got along, because I think you were never satisfied with, what are we talking about with level funding? That's totally, insufficient. But I will also call out that sometimes a win in advocacy is just bearing away a cut and staving off, major challenges, which may or may not be a little similar to the environment that we find ourselves in now. But it doesn't mean that we won't continue to ask and push for growth and expansion. And we are. ACH is very firmly behind that. But the things that I've always appreciated about you, Craig, is that, one, you had that light bulb moment that you just described in terms of going to the health center, which, again, we talk about that all the time in advocacy, where there's nothing more impactful than getting a member of Congress and to their staff, not just the member of Congress, and their staff to the health centers to see it with their own eyes, to have that light bulb moment. But you've always been about not just health centers, but patients. And I think that's a really interesting segue into what you're doing now on the Medicaid side of things. So tell us about that. What for those of us who don't necessarily find ourselves in the weeds of Medicaid and the program and MHPA, tell us about, just give us the overview of that.
Yeah, well, let me go back to the light bulb moment. The reason it was light bulb moment, because the way I grew up was in the communities that were underserved, right? I grew up in a very small town in Oregon, the booming metropolis of Rainier. Still the booming metropolis of Rainier. About 2,000 people lived in Rainier at the time. I think that's probably still the case. We had no medical facility that I could think of at the time. I think we had one dentist, Dr. Wardle. I knew Dr. Wardle. But we would have to leave the state. We'd have to go to Washington State across the river to get access to care. And so and I grew up, obviously the town was very low income. We were fairly low income. It was a free lunch program, and we would eventually make it to the reduced price lunch program. But I realized that my normal is the normal for a lot of people in this country. And so touring a community health center, I hate this term, and you're going to hear this a couple times. I hate it when it's like those people. We're helping them. What you're helping is the community, and you're helping my family and my town get access to care, be productive, engaged, healthy people. They're my family and my community. It's not those people that we're helping them. And so very, very excited to be at this current organization where I really get to see that for the whole country too, just from a different perspective. At working for community health centers from the organization perspective, I loved working there, as you well know. Went over to ACU from the provider, more the clinician perspective, and then here from the payer perspective, all still looking at the same issue and topic, which is care for underserved populations, just from a different perspective, from an organizational perspective, from a provider perspective, and now from a payer perspective. So I really enjoy it because you get to see it from a different perspective and how different levers help us, the community, succeed.
It's pretty amazing. I think one of the things that has always been very evident in your work is how visionary you are in terms of those levers and connecting dots that I think other people don't necessarily see, or at least not obviously. I do want you to go a little deeper into just in terms of Medicaid policy. And again, just thinking about people who are not necessarily living and breathing this every day. Just a quick snapshot of like, what is the state of Medicaid right now? And, let's just do that.
Yeah.
What's the state of Medicaid right now?
Well, let me first say the state of Medicaid. Medicaid is a widely varying program. I think people say, oh, Medicaid, but Medicaid pays for almost half the births of this country and more than half of the nursing homes of this country. All of the foster children, age, blind, disabled, people, incarcerated individuals, all different types of people across the country. It pays for, it's the largest payer, not a majority, but a largest payer for mental and behavioral health. If you're substance abuse. And so it's a widely varying population of people in Medicaid. And so it's hard to sit there and say this is the state of Medicaid, although we're going to get into a couple of those big levers that are happening right now. But Medicaid is so diverse. I think people look at it and say, oh, Medicaid, low-income individuals. You're like, oh, Medicare is old people, Medicaid is low-income people. That's not... It doesn't get into the subtlety of it, no. Which is there are literally millions of children. There are literally millions of frail elderly. There are millions of disabled. There's millions of people in all of these different sections of Medicaid that are material to the entire organization. So it's widely diverse. It's a diverse population of people within the Medicaid space. So let me just say that to begin with. But let me go also back to your comment, which was, sometimes level funding is a victory. Well, as you well know, this last year, that wasn't even the outcome for what we saw. We saw a Congress and a president take about $960 billion out of the financing for the program over the next 10 years. And so, and we'll need to talk about a couple of those things because a couple of them are coming up pretty quick. But $960 billion out of a program that serves those vulnerable populations is material. And so how do we respond? How do we look at that? And what can we do to make sure that people get the care they need throughout this process? And also, how do we advocate, right? Which is another huge part of this discussion.
Yeah. So one of the things I'm looking forward to talking about is it's less a commentary on right, wrong. It is policy now. This is the reality. We might have had different ideas of how it would shake out, but here we are. And I think to your point, really focusing in on what is it can we do to make sure that people have access to care. And I think that's where health centers and Medicaid and the work that you're doing are so incredibly linked, because I think there's a 100% alignment in terms of mission, in terms of making sure those people are getting the care that they need.
And are insured, that people are insured. And I get the access to care. That's what community health centers are excellent at, right? A primary source of care for populations that need it across this country. It should be for everybody, but we won't go there just quite yet. But the main source of bankruptcy in this country, medical debt. Yeah. The reason for that is because you were either uninsured or underinsured, or you lost your insurance as you got sick. Medicaid gets to help with that. Medicaid directly gets to help with that. Folks that are clearly cost conscious, that are sitting there saying, how much is this going to cost? Because they don't have those resources. They don't have that coverage. They need that coverage through Medicaid to keep them out of not just bankruptcy, but healthy. And so it's amazing to me what we allow to kind of happen in this country to folks that don't have those resources, that they should have Medicaid coverage. They should have comprehensive coverage that allows them to go get the care they need at a community health center and a whole bunch of tertiary and secondary places around this country. So it's frustrating to me that we're going to have more uninsured people in the country. We're going to have more medical debt in the country. We're going to have more bankruptcies in this country.
Yeah. I think there's another piece to this that I will, again, my voice is always going to be to connect back to health centers. I think the other thing that the reality of what we're facing is that, to your point, a lot more people are going to become uninsured. Health centers are going to be in a situation where they will continue to care for them regardless. Yeah. But those individuals who were on Medicaid and were predictable in terms of what health centers could count on from a reimbursement perspective are now going to be uncompensated. And since our funding on the health center side hasn't changed since 2018 in terms of grant funding, it just puts health centers in a very, very strained position on top of lots of other strains in the system right now. But I think the bigger challenge, and we're already hearing it, in fact, over the weekend, actually, I was reading some things and hearing from some of our health centers about people are already showing up and they don't have insurance. I have a friend who works at a hospital and in the mental and behavioral health space, and she was saying she's already having patients who are saying, well, I I don't know what to do because I can't get my prescription anymore, which destabilizes their mental and behavioral health, which then has a trickle impact on the rest of their health. So it's not an easy time right now, but I think we have a lot of work to do. Yeah.
Well, I think that we have a common goal within
Yes.
that, which is on the keeping people insured. Right? You guys are excellent at seeing the folks as they come through the door and saying, "Are you eligible for Medicaid?" Right? So you guys are going to be a critical component to the folks that show up that lost their coverage for another reason. I need to go through a couple of these provisions here in a second, but they're going to lose their coverage possibly through an administrative action. Right? They didn't fill out the right piece of paper.
Right.
They're going to come at a health center that they've always been going to. They're a community health center. And community health centers are excellent at enrollment, outreach and enrollment. And so ensuring that we continue to have that capacity at community health centers, because you're going to see a lot more people within the cycle, right? There are two provisions, if I can be so bold. There are two provisions that jump out at us right out of the gate. Everybody talks about the community engagement requirements, also known as work requirements. But we're also looking very closely at the 6-month redetermination, right? They moved that from a 12-month redetermination to a 6-month redetermination, which just doubles the number of redeterminations that a state has to do. I feel for the states. We're partners with the states. Our managed care, my members, the managed care organizations are partners with the states. They have a tremendous amount of work coming at them to implement all of these provisions, but doubling the number of redeterminations for Medicaid eligibility, you're just going to find cracks in that system. We went through a big process coming out of COVID. We had a lot of lessons learned that we can talk about, but this redetermination period and the work requirements where people are going to lose their insurance, not necessarily because they're ineligible, but because the paperwork didn't get done. And then they're going to show up at your health center, and that health center is going to say, "How do I get you re-enrolled?" That's going to be critical to keeping them insured and in a system of care. And my fear is that people may stay away because they think I've lost my insurance coverage and I don't know if I'm still eligible, right? Because that does make people hesitate on getting care. And so we need to avoid that as best we can. Health centers are in a critical part of that. Managed care plans, my members, in a huge part of that, because we stay in touch. That's the managed part of the managed care part, right? Which is, how do we stay in touch with our enrollees, with our covered lives, to keep them in the right part of care, right? Into primary care in particular, right? And so how do we make sure that they stay in care, and when their coverage might be coming to a redetermination period, how do we help them through that too? We can't re-enroll them. We're not the state. The state does enrollments. But we can help a whole bunch with education and information up to that point and say, this is what's coming, in partnership with the states, so that people know what's coming, how to get through it, and don't avoid care because they think they're uninsured.
Right.
That's what I'm trying to avoid.
Well, and I think that, going back to what you said, Medicaid is a very complex program. There's federal Medicaid, and then there's each and every state version of Medicaid. And so, health centers play, to your point, a huge role in the outreach and enrollment, again, in partnership with the states. Some states actually empower health centers to help directly with the enrollment. Other states say, no, you can bring them to this point, and then the state picks it up. But I think, to your point, the challenge is, I'm thinking of many of our health center patients, and again, it doesn't matter urban to rural. Many of them have multiple jobs. Many of them live quite a distance from where they're going to access their care. Many of them, English is a second language. There's so many different things that contribute to needing to be really thoughtful and intentional about the redetermination process and supporting them through that. I think about the work that health centers have done to try to address those issues, which they do routinely, not just for redetermination, but just to ensure that their patients can access care. But I think when you now layer in what we're going to be working through in terms of redetermination and the community engagement and the work requirements component, there's big concerns with that. Again, I think you're very correct in terms of worries over patients thinking, well, I don't know that I can have access because I don't know if I'm eligible. I don't know if I'll ever have insurance coverage again. What does that look like? You know as well as I do. It looks like unmanaged chronic conditions. It looks like much heightened ER use for things that they really frankly shouldn't be going to the ER for. It looks like medical debt, on and on and on.
It's also delayed. People will hold out going to the emergency room because they know it's going to be expensive, because they know they're uninsured. They know there's a problem here, which again gets back to your medical debt, which leads you to bankruptcy. I mean, it's not an unfounded fear. It's not an unfounded fear to try to stay away while I'm uninsured. Say, "Ooh, I can get through this," and that's terrible for our communities. And so it's the fear of being uninsured and then having a health concern that really makes everybody hesitate. But can I go back to one of your comments in particular? Expansion versus non-expansion.
Right.
I think this is a critical discussion, which is there has been a whole lot made of which provisions within the bill and the new policy is for expansion states, is for expansion populations and non-expansion populations. And I think we are clearly focused on the work requirements are in the expansion state, their expansion populations. I think there's a lot to be said about that, about how that's going to impact the greater healthcare landscape, because the people leaving are going to be often healthier, and in an insurance system, if the healthy people leave, who's left? Higher acuity people, higher cost folks. And so there's an impact that's resonating already today in that regard. But let me go back to the expansion versus non-expansion states. A lot has been made, this is focused on expansion populations in particular. But there's some financing mechanisms in there that are going to get rolled out over this 10-year period that's going to impact the country. And I think a lot of it is how the states finance their programs. You said it, every state is unique. That's the way Medicaid is designed. It's a unique state-federal partnership. State-federal partnership, right? Where the states design, every single program is very different in every single state. And their financing mechanisms are very different. So I don't know that enough is even known to say this is how it affects this state, just quite yet. I think we can talk about work requirements and 6-month redetermination because we know that comes out January 1st, right? States are working on a January 1st deadline on implementation of both of those, right? That's hard numbers. But the financing mechanisms are a little less well known, the individual state impacts. Some states are going to be like, oh my goodness, the way we've done it isn't going to work. We're going to try something new. And some states are going to say, oh, it doesn't work. I need to pare back, right? And some states are going to be like, okay, how do I get through this? But we don't have enough information to know how many billions of dollars that is per state yet to really know what that means for the population within these states. So you pick a state and you're like, how's the changing landscape? What should the health centers be looking for, right? How can we help? How can we all work together to get people care and keep them insured? We can talk about a couple of these provisions because we know a lot about them. Now we're expecting a lot more clarity, and there's still a ton of work to do, especially by the states. Unfortunately, the states there's just a ton of things coming at them. I said this a couple times. We're their partners, and we're like, how can we help? CMS is putting out information, but boy, it's coming fast. Yeah. January 1 is coming fast for community engagement work requirements and for redetermination. Redetermination, we did go through the end of COVID, so we do have a lot of experience in the redetermination space. We just didn't want to double it. Right. So I think there's a lot of best practices within the redetermination space where we could partner together, find ways to keep folks engaged. We did see a lot of variation by state. Again, a lot of variations by state because some of them do it a lot electronically, some of them don't. Some of them have addresses that have to mail it to a person, and some say, yeah, we can go ahead and let you guys text. Mm-hmm. Wow, welcome to the 2000s. But those are federal rules too. Don't be wrong. This isn't just states saying I can or can't do something. There are some federal rules that we've been pushing for. But we're going to see by state a widely varying impact. So health centers need to keep an eye on what's going on at the federal level and listen to what those big moving pieces are, those January 1st implementation dates. But boy, what's happening in those state legislatures is going to be as much or more important in the next short while they adjust to these new funding streams. And that just not enough is known right now. I can't sit here and say, Iowa is this impact.
Right.
Because I don't know if they know that direct number and how they would actually respond to that number, right? So we don't know just quite yet. There's still a lot to be determined. And again, hundreds of billions of dollars, not immaterial.
No, not at all. Not just a little.
Hundreds of billions of dollars.
Yeah. It's not funny. I'm not laughing because it's funny. I'm laughing. So sometime during the pandemic, it went, remember when millions was like normally the numbers that we were working in, and now it's billions. Now it's with a B.
Oh, it started at 2 trillion.
Yeah.
Yeah. Back to your success, your level, your measure of success. It started at 2 trillion, Amanda. We got it all the way down to 960. Yes. That's I don't know if you call that a level of a success, but that first list of proposals that was floated in Congress, twice as big of an impact. Yeah. And so that level of change within the environment is something we all need to be prepared for.
Yeah. So a couple things I want to focus in a little bit more on redetermination, and share some things that I remember, again, sort of as we went through this coming out of the pandemic. And again, it was different from state to state, but I do remember some of our folks sharing that there were sort of multiple waves with redetermination. It was not sort of on January 1st, all of the sudden you had this massive shift. There was some of that, but what they also realized was, whether it was, there's some number of physicals that happened in April, or there were sort of ongoing appointments, and many of which were scheduled at a certain time. That's when the waves were coming through, because it was just more people discovering, I'm no longer covered anymore. And so I'm curious to see, and now to your point, it's not just once a year, it's now going to be every 6 months. And so what does that look like for health centers? Again, I don't know that we can really anticipate that, but I'm curious couple things. What are you guys doing at MHPA in terms of, trying to support and anticipate what's happening with redetermination? And does that link to some of the trends that you've been seeing more recently in terms of enrollment?
Wow.
I know, it was a lot of questions.
This is a huge question, right? This is the big question, which is, how do we keep people insured, right? And what have we learned through that process of redetermination that is going to educate on this redetermination? What we know, there are a couple of things. A, the folks that we work with, our enrolled populations, your patients, have complicated lives. This isn't the first thing on their radar. Their insurance coverage, who is their health insurance, sounds very important to folks in the insurance space. I'm in the insurance space. It's critically important. I know how important it is to folks. But every day, they have a different challenge happening in their life. What we found out was you can't rely on one way to figure out how to connect. There isn't, texting works. There isn't that silver bullet. That we need advertisements on bus routes. Yes, you need that too. You need all of the things that we can do, engaging them. We have a whole raft of engagement strategies. I will tell you, one of my family members on Medicaid a long time ago, they would, not a long time ago, 4 years ago, they were like, our caseworker will call. And I'm like, you will never get through. Mm-hmm. He's not going to answer your call. I'm like, what do you mean? He's not? I'm the caseworker for the insurance. He's not going to answer your call. You know who will? His mother will get through. You could call his mom to get to him. It's that level of subtlety. Yeah. How do you stay engaged with somebody to make sure that they stay enrolled is going to take an individualized basis. That's where health centers are excellent, right? We do a good job of making sure we have that network of care, but you're going to see them in person, right? We have caseworkers and case managers and social workers and all these folks that are trying to help them through the challenges of their lives. You're going to see them at their door. right? You're going to see them at the door, and you're going to be able to say, how can I help you? Right? Which is what health centers do. Right. And so that level of partnership back and forth with us, doing everything we can, all hands on deck. There's not a silver bullet. There's not one thing that's going to answer this question. We have to do all the things. And then we also have to know we're doing it into turbulence.
Yeah. You know, like we were saying before, if you have a distance to get to not just your accessing your care, but to get to work, or you have kids and you're trying to make sure that they're triaged, you have extended family who have needs, you have language as a barrier. I mean, to your point, there are so many different things. The one thing I would say, and it reminds me, and I say this a lot, we talk about policy, and I think often what we need is a scalpel approach, and they use a sledgehammer. That is the nature of oftentimes with policy. This is one where the policy is actually in place, but now the approach, the execution of the policy similarly needs that scalpel approach, like you're saying, where you can, but that's extremely timely or time, exhausting. There's a lot of resources that go into it. There are so many different reasons that's not, snap your fingers and figure it out. But I will say, this is where I do think health centers, there literally is not a better partner, because they're so skilled at doing that.
I agree.
They treat every single patient with that individual approach to say, okay, Mrs. Lopez needs this, and she has, these family members living in her household. These are the things that we need to make sure we take care of before we can even get to these other things.
Exactly.
But the other thing I think that's really worrying or concerning is that, again, when we go back to what does this look like, I keep coming back to chronic disease management for some reason, where it's just like, okay, there's so many people that where health centers, frankly, and managed care have made such strides on improved health, where we're actually, it's not just improved quality of life and productivity in the community and all of the other things that we want to see for that individual. It's also savings to the system. It's also all of the other returns that from a policy and a government perspective they want to see, or I shouldn't say they, that we all want to see. But those things are easily damaged and washed away when you talk about, like you said, when you lose insurance, suddenly you don't have access to medication. Suddenly you're not having a provider who's checking in on you and the integrated care team who's making sure, have you stayed on top of these other really important health indicators to make sure that your chronic disease is managed. And so I don't know if I know that's a big part of the work that your members do. I don't know where that factors in if you're thinking about that part in particular, but
well, that's why your providers matter so much. Their ability to get through on chronic disease management. If you have a chronic disease, right, you have to be continuously engaged. And so we would like you to be continuously insured so that your continuous engagement gets paid, right, for those. An uninsured person is harder to engage in a continuous management activity. And diabetes, right? High blood pressure, all these different things, heart disease, these leading causes of healthcare costs and health challenges within the country. That's what health centers do. Right? And so making it through that with your providers, with our case managers and our folks and our entire network, right? This gets back to networks of folks. It's going to take everybody. It's going to take everybody on board trying to figure out how to navigate a turbulent life for our folks, our foster kids, our nursing homes, our chronic conditions, our age, blind, disabled, all these folks that have turbulent lives in a turbulent environment it makes it doubly challenging. And so, we all have to be on the same page with all of the activities. It's just going to take all of the things. The states are doing as much as they're getting information to be able to do. Right? They're getting all of the information they can do and trying to plan ahead, but these are tight timelines. Yeah. I mean, it's months from now. Months.
Well, can you speak to that a little bit? So what are we looking at in terms of like what's coming? Run through the timeline, and I know, there's sort of in the next 6, 9, 12 months, and then there's sort of beyond that, but maybe just run through the biggies that are coming down the pike.
Yeah, the biggest one, and some states are already starting to move. I think Nebraska is already on the community engagement discussion, trying to implement it. They're not gonna remove anybody, but they're trying to implement early. But January 1 is the work requirement / community engagement is how it's phrased, and also that 6-month redetermination. Now, 6-month redetermination, again, it'll roll out as it rolls out over that next year, right? But But look at the community engagement requirement. January 1, in general, you want to give people 90 days notice. That becomes October 1st, right? So October 1st of this year, right? People may start getting notices of requirements to do or file or do stuff. What are they going to get, right? What are they going to get? What does it say? What hoop do they have to jump through to maintain their coverage for something that will be impacted January 1, right? That's a big deal. That's right now. So I know, in talking to our state partners, those things that have January 1 start dates are the most urgent because they only have a matter of months to get those systems in place. Now, again, on redetermination, that also is January 1, but we've kind of been through that, so we kind of know, yes, can we maximize ex parte renewals? Can we get all of these information? What address are we going to use to make contact with these folks? Can we text them? Can we do all these things? All these answers are yes, do all the things. But states, I don't think you're hearing as much on the redetermination space because we kind of just went through that through the COVID unwinding. And they feel like, okay, I think we know what to do. Now, it was wildly differently successful in different states. Right. So we have a lot of lessons to learn within that space. But those are the two that jump out. But then state-directed payments, MCO tax, like the financing structures are a couple years into this structure. But there's a whole bunch of provisions over the next 10 years. Yeah. 10 years. Yeah. Now, the reason a lot of folks, to be fair, haven't really jumped to the 10-year mark on this even is they say, oh, there's going to be an election in Congress. So Congress is going to change. We'll see how much that changes. The president doesn't change for those 4 years, and so he signed this. Is he going to sign something that changes it dramatically? I don't know that we can bank on that. Right. We have to adjust for the 3 years that are on the implementation schedule. And so we really have to be in implementation phase, which is what you said. How do we work with all of our partners, federal, state, and local level, to make sure that people don't lose their coverage for administrative reasons?
Yeah, exactly. I agree. I'd love for you to speak a little bit to a couple things. Are there trends sort of at the state level, either, kind of reflecting on lessons learned, but also sort of what you're seeing right now that health centers should be paying attention to? And I would love for you to speak to, from your lens, it's not new anymore because you've been there for 6 years, but from your lens now, what is the role that health centers play for you guys, for your members, and the value that they bring, I guess? Yeah.
Let me go back to the landscape of what they're seeing. I think there's a couple of things that are important to note. The Rural Health Transformation Fund, I think is some states I have heard engaged the community health centers. I hope all of them did. I don't know that all 50 did, but I think that's a big tranche of money that will change the structures. It doesn't change the financing. It changes the structures of supposed to be rural health, but it's going to change state delivery models. Right. The structures, I think it will help. And a couple $100 million in a state goes a long way, real quick. But those are structural, it doesn't make up for the loss in coverages, right? So just want to be very clear. The Rural Health Transformation Fund, which leads to the technology space. There has been a lot of focus at the federal level of improving technology within the Medicaid space and the Medicare space, to be honest with you, the federal space, right? Which is, how do we do this in a more effective and efficient manner? We've heard that from CMS at all levels. How do we improve the technology that is being used? We saw some concerns, to be fair. The ex parte renewals, and I don't know how many health centers go into ex parte renewals, but those are like the automatic ones, right? You automatically qualify. We know from our own data, you don't have to do any paperwork. You're automatically renewed, ex parte. Those we love to see because you already have the information, right? I don't need to call you and say, your insurance might be going away if you don't fill out this piece of paper. I already know that it's not. Right. I'm going to automatically renew you. The more we can do that, the better. But states widely vary, and the technology available to mine data is widely varying. And I think that's one of those things where technology will help, right? It will dramatically help. who's stating automatically enrolled in these programs? It's going to help states. It's going to help our enrollees. It's going to help you guys because they're going to stay insured. So all of these things, technology, rural health transformation, and the technology change, not just through that, but organization-wide, from the federal level all the way through, I think will be dramatic. I think it's necessary, right? I think it is necessary because we're going to see such dramatic change. You take $1 trillion, I misspoke, $1 billion. You take $1 trillion out of a system, it's going to change dramatically. Can we make it more efficient and effective through technology? I think that's the question right now. Now, the next question is, do we have time?
Right.
I don't know, because January 1's coming up fast.
Yeah.
And so, but this is a 10-year rollout too. And can we make significant strides improving technology within this space to make this everything easier for all of us? You guys, us, federal, state regulators, everything. I hope so. I really, really hope so. But to your point, what role can community health centers play? You have to be connected into that, right? I think there's a tide change of technology coming through.
Yeah.
It's being pushed at all levels. Rural health transformation is just a part of that. But community health centers need to be embedded in that discussion because that is going to be the future for some time. If they're able to make the change they talk about, which is streamlining all these platforms and all this data collection and all these things that we do on the Medicaid space and enrollment and engagement and all these things, eligibility determinations, if we can improve the technology and we're relying on you guys as a backbone of the care for the primary care part, you have to be integrated into that from the beginning. So I think you guys really need to be engaged on the technology side, even though we're talking about work requirements and redeterminations. That technology side is going to be, I think, dramatic change. And so that's where we really need to leverage each other's engagement and strategies so nobody's left behind.
Yes. Yes, a million times. I think we have time for one more question or one final word. But before I do that, I will just say that I have big concerns about the Rural Health Transformation Fund. I think it's incredibly well intended. I will say, the health center losses alone in terms of projections is $35 billion. And so $50 billion over 10 years, which is a massive investment. It's a scratch of the surface. The other thing to your point is that some states have been really, really great about engaging health centers and bringing them in and making sure that they're not just sort of at the table, they're actually helping to really architect and design. But that's not the case in every state. And it's also, there's still a lot of unknowns in terms of how it's all going to shake out. And when we talk about technology, because I 100% agree with you that it's not just Rural Health Transformation Fund, the technology component of this is literally across the board. But there's a piece of that I'm still trying to figure out. I'm not going to say, there's maybe a little anxiety, but health centers don't have the resources to be able to throw dollars at new platforms and all of the different technologies that will assist in making this successful. Yeah. And so my urging for policymakers, particularly at the state level, is to prioritize health centers in terms of what that investment looks like. And frankly, for private and corporate to do the same thing, to understand that the investment in health centers is going to pay dividends because everyone's going to look at bottom line. That's just reality. We may be looking at patient, we may be looking at access. Most people are going to look at bottom line, whether that's profit or savings. Either way, the right investment and the right solution is health centers, but I think it's connecting those dots.
I agree with you 100%. Remember, the intent of that fund was never to offset losses.
Right.
People have said, oh, it's this much money. It had nothing to do with the loss in coverage and the loss in revenue streams from insurance.
Right.
It was about change.
Correct.
And so keep an eye on this hand. And also to your exact point, which is the speed at which they're doing it is going to be a challenge too, right? And all of this, the speed at which it's happening is going to be a challenge. So that rural health transformation is going to be instructive. Right. Can you do it this fast? It's a huge ask. And can you do it fast?
Right.
The same way with the provisions of HR 1.
Right.
These are huge changes and fast.
Right.
Can you do both? Not that we wanted either, right? Didn't want to lose coverage, didn't want to do a lot of these things. We opposed that bill, right?
Right.
not just for the change, but for the speed. And so the speed of this is going to be instructive. And the rural health transformation, I'm not calling you back from the edge on that, which is, and the hesitancy on that. I think it'll be instructive.
Yeah.
How fast can you do massive change? And can you do it successfully? Because the people we work with, the communities, our friends, our neighbors, our families, this is incredibly, incredibly important.
Right. Okay, so final word.
Oh.
What is your final word or parting words for those folks in the health center space? If you had one message for them to take away through the lens of where we are with Medicaid and what's coming, and then for policymakers, I think, frankly, we've already talked about how intertwined the work that you're doing now and the work of health centers. But so those two, what are your final words for health centers? What are your final words for policymakers?
I saved my policymaker one for later, but my one for health centers is easy, which is it has to be all hands on deck. Managed care sees community health centers as an integral partner in making sure people get the care they need, but also stay insured. Your engagement folks, your enrollment folks are what matters too, right? It's the care they receive and getting them re-enrolled, because you guys are going to bear the brunt of a lot of that. You've seen it. You know it. You have the folks come in that are uninsured, that are still eligible. Right. They just didn't make it through the administrative hoop, and you guys help them through that. So it's a collaborative relationship, a critical relationship for managed care, to have somebody that we know is going to see everybody regardless of ability to pay, screen them for their eligibility, and make sure they get enrolled when they can. But we're going to do the best we can to make sure they get in to see you too, even when we know, this date is coming up. We need to get you in and get you through the enrollment process, get you re-enrolled, and keep you on insurance, because the most important thing is making sure eligible populations stay enrolled. Mm-hmm. And so there's going to be a lot of jumps, a lot of hoops come from here, a lot of turbulence. I guess that's my theme for this whole discussion. But my message for policymakers is that we're going to have to pay really, really, really close attention to what you intended for this, and how it's actually implemented on this, and these deadlines, right? And how can we keep people insured? I'll tell you, we're pushing a bill to extend continuous enrollment, to extend enrollment for 12 months for certain populations are never going to fall off. Just make sure that these folks stay insured and don't do every 6 months. They have a continuous eligibility. We're going to be looking for those opportunities where we can keep eligibility for enrollment longer, so that people stay insured and they don't have to jump through another hoop when they already have massively turbulent lives. We need to help them. You guys do that. We have a whole teams and teams and teams of people to do that. We need to all be on doing all the things all together to make sure that works.
So thank you for that. The other thing I would add is that, because I have been really privileged to be able to work with a number of your members, and they want to work with health centers. They want to figure out how to make this work, and they welcome ideas. That's something else I've really appreciated, is that they understand as well as we do that it's not a one size fits all. And so if a health center or a state recognizes that there is a specific need that requires a tailored approach, again, that scalpel versus the sledgehammer, your members are frankly wonderful partners in that space, and they have resources. I'm not going to overdo on that, but they have resources to support it.
It's their job.
And everybody's after the same mission, which is making sure that people have continued access to care and coverage.
And our job is to have an adequate network for the populations we cover, and that's why health centers are critical. By definition, in underserved communities, right? By definition, you're in an underserved community. We need to make sure people have access to care. I can guarantee you all of our folks are thrilled to work with community health centers, but yes, some are doing a ton directly to make sure that they have that network adequacy in underserved communities that you guys serve.
Well, next time we're going to talk about workforce.
Oh, yeah.
Which we don't know anything about between the two of us. But thank you so much for the work that you're doing and for the conversation and for all of the advocacy that you've done for underserved communities and patients, and for your history with health centers. We were speaking in a different podcast about standing on the shoulders of giants. I would categorize you as one of those giants, so thank you.
Well, I've stood on the shoulders of many of those myself, so very excited.
Yeah. Craig, thank you so much for joining us and for helping bring clarity to a system that plays such an important role for so many people. What stands out from this conversation is just how much coordination it takes to make Medicaid work well. From health plans to providers to policymakers, all working toward the shared goal of delivering access to care. And for health centers, that partnership is essential. As the landscape continues to evolve, the ability to stay aligned, adapt, and keep patients at the center will make all the difference. For those listening, this is a moment to stay engaged, stay informed, and continue strengthening the relationships that support the people and the communities we all serve. Thanks for being with us, and we'll see you next time.